acute pulmonary embolism in post-operative patient as a case-based discussion. So remember, you can get PE maybe in the post-operative period, or a patient who is having a risk factor who can land in ER with pulmonary embolism without any post-operative uh, like time, or the patient may be pregnant who presented with pulmonary embolism, obese with pulmonary embolism, prothrombotic like status pulmonary embolism. So, or maybe like post chemotherapy, solid organ malignancy, like again can manifest in the ER as a pulmonary embolism case, or it may be a case of pulmonary embolism who is a post-operative patient and gone home. So again came back with pulmonary embolism. So the scenario, the case may be anything. Here we'll try to like look in and around what are the important aspects in managing a acute PE patient in the post-operative period. So in terms of the risk stratification, in terms of therapeutic options, so in terms of the anticoagulation, when to initiate, what agents, pros and cons, so and the long term like outcome predictive analysis and all those things, very very important. So like we'll go ahead with the case based discussion, acute pulmonary embolism in a post operative patient. So 62-year-old male patient weighing around 82 kg. So known case of hypertension and diabetes, type 2 diabetes. So he was having a road traffic accident. So presented with unstable pelvic fracture. So he underwent open reduction and internal fixation under general anesthesia. Total duration of surgery is around 4.5 hours. Estimated blood loss of around 1.2 liter. He received two packed RBCs intraoperatively. So post-operative period, so it's been started on mechanical DVT prophylaxis. So low molecular weight heparin deferred. So in view of the high bleeding risk, because he received two packed cells, they thought okay in their so protocol they thought it is okay to go ahead with the DVT prophylaxis. They have not given the low molecular weight heparin as a pharmacological DVT prophylaxis. Okay. So that was the day 0, day 1 to 2 in the post-operative ICU. So he's been extubated on post-op day 1. So hemodynamically stable, mobilization limited due to pain. So he was saturating around 97% on nasal oxygen, no fever. We got his labs HbS 10.2 post-operative period. So marginal leukocytosis was there 13,800, platelets were adequate. So it is around 2,10,000. Okay. So day 3, so there was a sudden deterioration. So sudden onset of severe dyspnea, chest discomfort, so restlessness. So his heart rate become 126 per minute, BP dropped to 76 by 48. So respiratory rate is 34 per minute. So saturating around 82% on so non-rebreathing mask of 10 liter oxygen. So almost 60-70% oxygen is started requiring. So is afebrile. His urine output is less than 0.3 ml per kg per hour in the last couple of hours. We done an ABG. ABG shows like with a 10 liter of oxygen. So FiO2 nearing to 100%, may not be 100%. So 10-12 liter, more than 10 liter, we can consider at least 70-80% of the FiO2. So pH of 7.28, PaO2 of 52, PCO2 of 30. So bicarb of 14, base excess is -10, lactate is 5.8. So he started on norepinephrine 0.2 mics per kg per minute. So interpret this ABG. So what are your immediate differential diagnosis in this post-operative patient with a sudden dyspnea and shock? So these kind of cases are very common. So in a high-end tertiary quaternary care center, so how you are going to deal with this kind of patient? So first question is like interpret this ABG. So examiner might be interested to know how you are going to interpret this ABG. Okay. So first, see the oxygenation. So assume so it's almost requiring 100% oxygen. So more than 10 liter on NRBM. So PO2 is 52. There is a severe hypoxemia is there. So refractory hypoxemia, very low PO2 despite the high oxygen. So it suggests either there is a shunt physiology, severe VQ mismatch, maybe underlying ARDS, massive pneumonia or pulmonary embolism. So these are some of the causes for severe VQ mismatch. So if you see the acid-base status, pH is 7.28, acidemia, primary disorder with a bicarb of 14, which is low. So with the base excess of -10, so it is a primary metabolic acidosis. So in primary metabolic acidosis, we know that we calculate respiratory compensation using Winter's formula. So expected PaCO2 so is equal to 1.5 into bicarb plus 8 plus or minus 2. We got like measured PCO2 is 30. So expected is 29 plus or minus 2. So it means appropriate respiratory compensation is there. It is in the range of what we expected. The measured PCO2 came in that range. Okay. So there is no additional respiratory acidosis or alkalosis. Lactate is 5.8. So high lactate, high anion gap metabolic acidosis. So likely due to tissue hypoxia, shock, hypoperfusion. Okay. So integrated oral interpretation, severe hypoxemic respiratory failure. So high anion gap metabolic acidosis looks like secondary to lactic acidosis. So there is an appropriate respiratory compensation. So underlying shock state with impaired oxygen delivery. So that is the your ABG based diagnosis. Very, very important. So you need to complete and give an inference what exactly is happening based on the ABG. Okay. So next question asked was what is the differential diagnosis in a post-operative patient with having a hypoxia shock? So we have to categorize either pulmonary or cardiovascular causes. So first differential diagnosis, massive pulmonary embolism. Remember in your exam also, when you give differential diagnosis on hierarchy, you should give a rationality for that. Very, very important. Okay. Why you consider background of pelvic fracture, prolonged surgery, immobility, no chemoprophylaxis because of the bleeding risk. So presented with sudden hypoxia, shock, tachycardia. So like RV failure is the reason with a rise at CVP. So key points how we can work out further is echo, RV dilatation should be there, sometimes McConnell sign. So CTPA is confirmatory, like if there is a possibility to shift. Otherwise, so echo with a background of clinical scenario, you can diagnose it has a like massive pulmonary embolism. Fat embolism syndrome, next differential, long bone pelvic fracture, hypoxia plus contusion with Petechi you need to see, like usually it appears 24 to 72 hours. Usually they will not have a shock. Chest x-ray shows some sort of diffuse infiltrates. So that is how we can have some DD. Tension pneumothorax, again post-op in a ventilated patient, that is common. So but this patient is extubated, less likely, but the clinical manifestation remains sudden hypoxia, hypotension, so unilateral absent breath sound. So immediate clinical diagnosis is the clue for tension pneumothorax. Okay, air embolism. So patient underwent open reduction internal fixation. So there is venous exposure. Sudden cardiovascular collapse is there in the post-operative period. So you can see for the mill wheel murmur. So the diagnostic is transesophageal echocardiography. Acute RV infarction, so elderly diabetic background. So usually they present with a clear lung field because it is an RV is not able to pump. So there is no problem with the pulmonary congestion. It is not the LA-LV involvement with the back pressure on the lung. So clear lung field, lung pulmonary oligemia is the characteristic finding of RV infarction. Very, very important. Okay. With like back pressure rise with a rise at CVP and all. So ECG shows inferior wall MI and echo you can do to get an idea about the regional wall motion abnormality. So here sudden hypoxia, so plus an obstructive shock. So think about pulmonary embolism until proven otherwise because of the clinical background and supportive clinical clues the patient is having a manifestation. Okay. So there is an integrated differential diagnosis in the post-op sudden hypoxia plus shock excluding massive PE. So if you see massive PE as one of the DD, what other DDs you can consider? But remember, you need to give some sort of rationality when you tell all these things, whether it's a cardiac, like acute MI, RV infarction, acute LV failure, malignant arrhythmia. Okay, to look for some sort of perioperative stress. He was a diabetic, elderly. So for LV failure, acute fluid shift will be there, massive transfusion. So malignant arrhythmia because of electrolyte shift, hypoxia can be the reason. Do an ECG, echo. Okay. So auscultation, pulmonary edema, crepitations, ECG shows some sort of the rhythm disturbances. Suppose if it is a pulmonary but non-vascular differential diagnosis, then you have a tension pneumothorax. So sudden collapse with like decrease in that side ventilation, unilateral absent breath sound. So towards the tension pneumothorax. Fat embolism syndrome, as I already discussed. So hypoxia, some neurological signs, petechi will be there with a background of pelvic fracture. So aspiration pneumonitis, patient underwent general anesthesia in the post-operative period. There is a possibility, usually there is no shock in immediate aspiration pneumonitis. So trolley, there is history of recent transfusion. So usually it present with within 6 hours of the transfusion with acute hypoxia. Usually they have a normal blood pressure. There is no shock in trolley. Very, very important. Okay, so all these things, differential diagnosis, you need to remember and you should give the rationality. Next is hemorrhagic or distributive shock. So post-operative bleeding, because it's a major pelvic surgery. So usually they will have a hypotension, may not have a severe hypoxemia. Okay. So septic shock, it is too early to tell because trauma is there, post instrumentation. So they will have a hyperdynamic shock, that is a warm shock like a distributive shock, may not be an obstructive shock pathophysiology. Okay. So this is one way of like putting the differential diagnosis other than the massive pulmonary embolism. So can you comment on so different diagnostic scores for suspected pulmonary embolism? Okay. So we have many pre-test probability scores which we can use before imaging. So this is an overview on what scorings. So examiner may be interested to understand what you know about the scoring system in terms of sensitivity, specificity, where we can use. So even though you don't remember different components in each score, at least you should know where to fit these kind of pre-test probability scores. So use it before making any imaging arrangement. Okay, well score for pulmonary embolism, like it categorize the patient into low risk, so moderate risk or high risk, or it tells about P is unlikely or P is likely. Okay, so most commonly used in emergency department and ICU. Good sensitivity around 85 to 90%, but the specificity is low to moderate, it is around 40 to 50%. Okay, so it tells whether we need to go for D dimer or CTPA based on the probability score. If the probability score is low, okay, low risk, then we can do the D dimer. If it is positive, CTPA. So the probability risk is moderate to high, then straight away go for CTPA. Don't do the D dimer. D dimer can come false positive in critically ill patient. So onco patients, ongoing malignancy, pregnancy, elderly patient and all, very, very important. Okay. So next is revised Geneva score. Again, it tells about low probability risk, intermediate or high risk. So when avoiding subjective judgment, you can go for the revised Geneva score. So sensitivity is very high, specificity is low to moderate. So it is entirely objective. Okay. So then going subjective, we can use Geneva score for objective criteria. So then there is a simplified Wells or a Geneva score. So it reduces the variables as compared to the original Wells score. So it again tells P is unlikely or likely. Okay. So rapid bedside use is the like utility of this one. So high sensitivity, low specificity, similar performance as compared to other probability scores. Okay. So there is one score, one algorithm called years algorithm. So I will not put the entire years algorithm here. So it includes 3 items plus D dimer cutoff. So it is a rule out strategy. So it helps in minimizing the CT scan requirement. So which is having a very good high negative predictive value. So increasing emergency department use, so like is for the years algorithm. So remember, years algorithm is having a very good negative predictive value. So there are some rules or the scores which we can help in ruling out the pulmonary embolism in a low risk patients, only in low risk patients. Okay, there is something called PERC rule. So when to use very low clinical suspicion, when we are suspicion is very, very low probability, so rules out PE without the D dimer. So that is a PERC rule. So sensitivity is around 97 to 99%, low specificity. So use only if pretest probability is very low. So in moderate to high, pretest probability is not going to be helpful. So D dimer, but again you need to adjust for the age. As I told, in elderly, it may be false positive. So when patient is low to intermediate risk, so it excludes the pulmonary embolism. So D dimer negative, So fairly exclude pulmonary embolism. If it positive, it is not a confirmatory. So it is very highly sensitive, but specificity is very low. Okay. Again, if D dimer comes negative in a low to intermediate risk category patient, so it reduces the need of like CT scan. Unnecessary CT scan can be avoided. So next, venous thromboembolism risk. So it is not for pulmonary embolism. It is not a PE diagnostic. So, but it is a VTE risk stratification score. Something we have Padau score. Okay. So what it predicts? It predicts risk of venous thromboembolism in hospitalized medical patients. Okay. So it tells about prophylaxis decision. So high sensitivity, low specificity. It is not a P diagnostic score. It is a venous thromboembolism. So risk score. So if the score is high, it tells okay, you need a like DVT prophylaxis. Then there is something called Caprini score. This particularly applies to surgical venous thromboembolism risk. So that is what we are dealing with our patient who underwent a pelvic fracture repair. So it tells about the surgical prophylaxis is needed or not. Sensitivity is high. So low specificity, not for again diagnosing the pulmonary embolism. At least some of these things you should remember. Okay. So this is the Caprini score. So it tells about the venous thromboembolism risk assessment in the surgical patient. So it adds some components of the age, surgery, mobility, history, medical condition, other risk, and the major trauma like neuro or other major trauma. So it gives the point. So depending upon what component we are using, if the total score is 0, so it is very low risk for the VTE. Early ambulation is sufficient. 1 to 2, so low risk for venous thromboembolism. Mechanical plus or minus ambulation is okay for DVT prophylaxis. 3 to 4, moderate VTE risk. So then here definitely they require low molecular weight heparin, but if there is a contraindication, we can go for the mechanical thromboprophylaxis. If the score is more than or equal to 5, so then definitely they are high VT risk. So they need pharmacological plus that of the mechanical thromboprophylaxis. So the Caprini score so stratifies surgical patient for venous thromboembolism risk to guide prophylaxis and is not a diagnostic tool for the pulmonary embolism. Very, very important. Okay. So the take home, how to use in practice, even in exam, suspected PE, we can use Wells or Geneva score, low probability score. So do the D dimer if it is negative, so PE is going to be excluded. High probability, don't do the D dimer, directly go for the CTPA. Very low probability, we can do the PERC score. So no test if all negative. So if everything comes negative, no need to go for the further test and all. So if you see the sensitivity and specificity, high sensitivity which helps in ruling out the PE. So well score with a low risk stratification, it rules out Geneva, PERC and D dimer, which we can use for ruling out. If everything is negative, so it fairly rule out the pulmonary embolism. Low specificity, all clinical scores cannot confirm the PE. So confirmation definitely require a CTPA or VQ scan. Okay. So the take home message, Wells and Geneva score are used to estimate pre-test probability of pulmonary embolism and guide D dimer needed or not. Low to intermediate probability, do the D dimer. D dimer negative, so rules out the PE. Positive, we need to confirm with that of the CTPA. So D dimer or imaging, while Padau and Caprini score assess the venous thromboembolism risk for prophylaxis, like prophylaxis should be given or not, and should not be used to diagnose the pulmonary embolism. Very, very important. Okay. So coming back to our patient. So this is the ECG we got in our gentleman who underwent like pelvic fracture repair and he had a next day 3 collapse, hypoxia, hypotension, NORAD requirement. So this is the ECG. So what is happening? And next leading question is, what are some of the common ECG findings which we can expect in acute pulmonary embolism? Very, very important. Okay. So here the patient is having a sinus tachycardia. So heart rate is around 120 per minute. So RBBB pattern is there. So negative T waves in V1 to V3. Okay. So V1 to V3 is having a negative like V1 to V1, V2, 3 negative T waves are there. So with S1, Q3, T3 pattern. So this is the S wave in the lead 1. So S wave. Okay. So Q wave in the lead 3. There is a Q wave. Inverted T waves in lead 3 again. So that we call it as S1 Q1, so T3. Okay, so S1 Q3 T3. So even though it is not so common, not sensitive, but it is specific for the pulmonary embolism. So extreme right axis deviation is a dominant R wave in the AVR. Okay, so R wave is dominant in the AVR. So this is the ECG interpretation. So what you need to remember, high sensitivity screening clue, sinus tachycardia is the most common ECG manifestation of pulmonary embolism. Very, very important. In the same way, most common EBG finding in pulmonary embolism is respiratory alkalosis. Because of tachypnea, patient is going to wash out the carbon dioxide. So high specificity, diagnostic and prognostic clue. So S1Q3 T3, it is not so common but highly specific. RBBB, dominant R wave in the AVR, ST elevation in AVR. Okay, so these are the specific markers of the pulmonary embolism. Markers of high risk or massive PE, patient is having RBBB pattern, extreme right axis deviation, ST elevation in AVR, and widespread T wave inversion. So this tells about there is a massive PE. Okay, so these are some of the common ECG findings with their sensitivity, specificity, and what you need to remember. Please go through this table. So, but as I told, most common manifestation is the sinus tachycardia. It is around 60 to 70% sensitivity. So, normal ECG can be seen in around 20 to 30%, but it does not exclude the PE. S1Q3 T3 pattern, so approximately around 10 to 20%. So, low sensitivity, but very good like specificity. So, which because of the acute RV strain. So, right axis deviation, extreme right axis deviation, or dominant R on AVR. So RBBB either complete or incomplete, T wave inversion in V1 to V4 plus or minus lead 3 AVF, ST depression in V1 to V4, ST elevation in AVR plus or minus V1, P pulmonale, atrial fibrillation or flutter. So S1, S2, S3 pattern, QTC prolongation. So these are some of the ECG findings which you can expect in pulmonary embolism. But at least couple of things you should remember, like S1Q3 T3, sinus tachycardia, right axis deviation, RBBB, T wave inversion. So all these things are very, very important in terms of sensitivity and specificity. You can go through this table. Okay. So next question, what is your next bedside investigation? See, do you feel this patient who is requiring NORAD? So hypoxic, hypotension, is it a good idea to shift him for the CT pulmonary angio? So no. So risk stratification, high probability of P is there. So shock is there in this patient. What bedside investigation we can do? We done a echocardiography. Okay. So this is what we saw. So this is the IVC. This is the TAPSE we monitored. So this is the echo. So there is a significant RARV dilatation is there. So apex of the whole art is like formed from that of the RV. So RV apex is looking like an overhanging. So there is a septum is moving towards the LV with a tachycardia. So again, LV caliber looks compromised. Okay, again, so this is the inverted D sign. So which we get in the massive pulmonary embolism. So when there is a compromised caliber of the LV, so there is a LV filling is going to be decreased because of the interpulmonary means ventricular interdependency. So then like there is a low cardiac output and shock is going to be worsened. Okay, so comment on the echo findings here. So echo shows dilated RV to LV ratio is more than 1. So septal flattening, D-shaped LV is there, tap size around 12. So McConnell sign is present, IVC dilated and non-collapsing. So this is the overall interpretation. So tricuspid annular peak systolic excursion tap say. So if you put like your M mode, so across the tricuspid annulus somewhere here, so this gives the tap say, like this is where you put the M mode. So while monitoring the tap say, okay. So then if you measure the tap say, so normal should be more than 1.8 centimeter, that is 12 millimeter. Mild to moderate RV dysfunction 1 to 1.8 centimeter. So severe if the value is less than 1 centimeter. It tells about the RV dysfunction. Okay. So based on your clinical echo findings, how will you risk stratify this patient? So patient looks like a very high risk. There is a massive pulmonary embolism because patient is having shock, RV dysfunction is there, high lactate hypoperfusion is there. So there is a high mortality risk is there. Okay. So your interpretation keys, what you need to remember, most sensitive echo marker is RV dilatation, RV dysfunction, but not specific. Most specific for acute PE, that is McConnell sign. So that also we call it as a 60-60 sign. So marker of high risk or massive PE, RV dilatation plus dysfunction, septal flattening is there. So here if you see, so like inverted D sign is happening. Okay. So it looks like a inverted D sign. So that is a septal flattening is there. So low TAPSE, if the TAPSE is less than 1 centimeter, it is a high risk. So elevated TR jet with shock. When you do Doppler, okay, so while doing the echo, if you see the TR jet, if it is increased, so that also tells about high risk pulmonary embolism. Okay, echo cannot rule out PE. Normal echo does not exclude the PE. Still, there is a subsegmental PE. See, the predictiveness of echo increases when there is a like worsening up of the hemodynamics. It means so patient is in shock, more than 50% caliber of the pulmonary artery is occluded because of the thrombus. That impact on the echo with RV dilatation, RV dysfunction, RV to LV ratio is going to be more than 1. So in a stable PE, echo may looks normal, they might be having a subsegmental pulmonary embolism. So echo is for risk stratification, so not an exclusion. Okay, but when you have a high risk category, shock is there, so then the predictiveness using echo is going to be positive predictive value is going to be increased with the RV, RARV dysfunction. Okay, so these are some of the echo findings in PE with their sensitivity, specificity, and how frequently we get that like picture and all. Okay, so RV dilatation, that is RV to LV ratio is more than 1. So acute RV pressure overload is the reason, that is what it reflects. So approximately around 30 to 50% patient you can get. So good sensitivity, specificity is means sensitivity is around 40 to 50%, specificity is around 80 to 90%. It is a common marker of significant PE. So RV systolic dysfunction, RV failure. Okay, so again, it is a prognostic marker, worse outcome. McConnell sign. So RV free wall hypokinesia or akinesia with apical sparing. So apex is like moving good, but the free wall is hypokinetic or not moving at all. So that suggests about the acute RV infarct. Again, it is happening only in 10 to 20% of the patient. These are all not common. Like even S1, Q3, T3 also it is around 10 to 20%. So, but very good specificity around 90 to 95%, not sensitive, highly specific for the acute PE. So then we have interventricular septal flattening, that is a D sign. So left wave, left ventricle short axis, we can get this D sign. So RV pressure load is the one which causes this D-shaped like septal flattening. Again, it is around 22%, 20 to 40% we can see, it indicates acute pulmonary hypertension. Okay. So TAPSE, elevated TRZ, 60-60 sign. It means TR gradient is less than 60 millimeters of mercury. Okay. Plus, so right ventricular outflow tract acceleration time is less than 60 millisecond. It is suggesting acute PE physiology approximately in 10 to 20% of the patient, specific for acute but not for the chronic pulmonary hypertension. Okay. So there are other findings like sometimes we can see the pulmonary artery thrombus inside the like right atrium in echo. So LV underfilling, paradoxical septal motion, okay, dilated IV and reduced collapsibility, which suggests raised RA pressure in about 30 to 50% you can see, which support the RV failure. So just go through this interesting echo findings in pulmonary embolism. Very, very important. Okay, at least so some common findings you should be aware for your exam purpose. Okay. So this is again one table which suggests a massive PE based on ECG, echo and CT. So ECG, if patient is having like T-wave inversion in V1 to V3, RV strain, RV dilatation and echo, visualization of the large clot burden in pulmonary artery itself on the CT. So it suggests the massive PE. Okay. So these are some of the findings which you can go through. So already we discussed ECG and echo, which suggest the massive PE. In terms of CT, increased diameter of SVC, IVC and pulmonary artery, large clot burden in the pelvis or legs, right to left ventricular diameter is more than 1. So leftward septal bowing even in CT, angio, CT pulmonary angio. All these things suggest the massive PE. So clinical forms of PE, again, you can categorize, okay, acute minor, acute massive, subacute massive. Acute minor, so short, sudden onset history, so vascular obstruction, that is a pulmonary trunk obstruction is less than 50%. Usually they manifest with dyspnea, with or without pleuritic pain. Sometimes they can have hemoptysis. So pulmonary artery pressure is normal, right atrial pressure is normal. Acute massive, they present with short, sudden onset of breathlessness. Okay, more than 50% caliber is compromised with the thrombus. So right heart strain with or without hemodynamic instability and syncope will be there. So usually their pulmonary artery pressure is around 45 to 20. Okay, so right atrial pressure is around 12. So subacute to massive, so it is the history several weeks. So more than 50% caliber is compromised. So they present with dyspnea with the right heart strain. So usually their pulmonary artery systolic pressure may be 70, diastolic is around 35. So right atrial pressure is around 8. Remember, in acute massive PE, so usually the pulmonary artery pressure will not go beyond 45 or maximum 50, because to build up that pressure, right ventricle has to hypertrophy. Means it needs some time. In subacute to chronic, so RV become hypertrophic, then only it is able to generate so the pressure in the pulmonary artery beyond 50, 55 and all. So that's why in subacute massive you can get 70 systolic of pulmonary artery pressure, but in acute massive it is hardly around 45 to 50. Very, very important catch. Many times it is very difficult to differentiate whether it is an acute PE or like carpal nail with COPD background that is causing the pulmonary artery hypertension. Usually in those scenario RV is hypertrophied, so pulmonary artery pressure may be beyond 50. But in acute PE, massive PE, usually it's going to be less than 50, 55. Okay. So what is the standard first line of reperfusion therapy in high risk PE? So forget about our patient, but if patient is having a high risk PE with unstable hemodynamics, so standard way of therapy is systemic thrombolysis. Okay. So, but in our patient, so why thrombolysis is problematic? Because recent major surgery, that is a pelvic surgery within 72 hours, high risk of catastrophic surgical site bleeding if you consider for that of the like thrombolysis in our patient. So it is some sort of relative to near absolute contraindication to thrombolyze a post-operative pelvic surgery patient who had a massive pulmonary embolism. Okay. So outline an overview on the management of a case with a suspected PE. Suppose you have a patient so whom we are suspecting pulmonary embolism. What is your approach? So that is the examiner's next question. So this is one of the fantastic flow chart. Okay. If you suspected a PE, consider anticoagulation pending diagnostic evaluation. So even though you are doing a diagnostic workup, so don't wait, at least you give one anticoagulation. So determine the clinical probability of PE, maybe Wells score, Geneva, whatever you use. So if the probability score is low, so then you do the D-dimer. If it is negative, pulmonary embolism is excluded. If it comes positive, so then pursue the other test. Okay. So if the probability score is moderate to high probability, so hospitalize the patient. So then the diagnostic options are either you get a helical CT. If it is positive, treat it as a pulmonary embolism. If it is negative, P is excluded. Okay. So VQ scan is one option. Again, it tells about high probability, then treat it as a PE. Low to medium probability, pursue VQ scan. So our helical CT pulmonary angio should be the option. Okay. So if VQ scan is normal, pulmonary embolism is excluded. So with this, you should do the lower extremity like Doppler study also. If it is positive, so origin of P is from that of the DVT. If it is negative, so pursue VQ scan and CT angio if there is a high clinical probability of the pulmonary embolism. So this is one of the simple understanding of a workflow for a suspected pulmonary embolism. Okay. So coming back to our patient, what are the indications for mechanical thrombectomy in PE? So our patient definitely is not a candidate for thrombolysis. It is a relative to near absolute contraindication. So we undergone catheter directed mechanical thrombectomy for our gentleman who had a PE. Okay. So high risk pulmonary embolism. So contraindication to thrombolysis, or you attempted a thrombolysis but failed thrombolysis, or you are attempting and complication of thrombolysis happened, so then it is an indication for mechanical thrombectomy. So rapidly worsening RV failure, persistent shock despite of ongoing vasopressor therapy. All these things are the indications for the mechanical thrombectomy. Again, these are some of the landmark trials and registries on mechanical thrombectomy in pulmonary embolism. You can just go through it. FLAIR trial, so extract P, FLASH registry, FLAME, Peerless, okay, Seattle 2. So these are some of the clinical trials, so landmark trials on the mechanical thrombectomy in like pulmonary embolism. So indication when to consider: when thrombolysis is absolutely contraindicated, or you attempted and failed thrombolysis. So complication of thrombolysis, rapidly deteriorating, significant shock is there. So with worsening RV failure, you can consider for the mechanical thrombectomy. So suppose you consider for thrombolysis in regular, massive, high risk, unstable pulmonary embolism, what are the available thrombolytic agents? So can you compare all those things? Okay. So examiner might deviate your case flow also. He is interested to know what is your knowledge on available thrombolytic agents in pulmonary embolism. Okay. So remember, so our thrombolytic agents, we have streptokinase, so alteplase, that is tissue plasminogen activator. So tenecteplase, that is like highly fibrin specific. Okay. So streptokinase is non-fibrin specific, which is the non-specific. Alteplase, it is fibrin specific. Tenecteplase is highly so fibrin specific. So streptokinase forms complex with the plasminogen. So like that leads to plasmin. So here alteplase, it is a direct plasminogen activator. So tenecteplase is genetically modified tenecteplase. Okay, tissue plasminogen activator, which increase fibrin like affinity and decrease the plasminogen activator inhibitor. So thereby it potentiate the lysis capacity in a specific way. So definitely overall fibrin specificity is good with alteplase and tenecteplase, which is very, very good. So streptokinase is a non-specific. Okay. So you just go through this table, which gives about the dose. Okay. So like if you see, like single dose is with the tenecteplase. So that is like weight-based single dose, but it is an off-label usage in pulmonary embolism. So alteplase 100 milligram over 2 hours we give. So initially maybe 20 milligram you can give it as a rapid push, and remaining 80 to 90 milligram you can give it over 2 hours. But if patient is having a massive cardiac arrest, you can just push maybe 50 milligram bolus, another 50 milligram you can give it later, means in the remaining 1 hour. Okay. So like cost cheapest is streptokinase. Both alteplase and tenecteplase are expensive. Current guidelines rarely recommend streptokinase because of the non-specificity, systemic bleeding risk, and bleeding risk of the inside the brain. So preferred agent is alteplase. So selected users mainly for MI, okay, emerging data in pulmonary embolism for tenecteplase. Even though it is not like included in the guidelines, but lots of data is emerging in terms of using tenecteplase. Remember the standard dosage of like streptokinase, we give 250,000 international units bolus, so followed by 1 lakh international units per hour. So for the 24 hours infusion, so that is for the streptokinase. So these are some of the comparative data. Okay. So the take home: among thrombolytics, alteplase is the preferred agent for pulmonary embolism due to fibrin specificity and acceptable bleeding risk. So tenecteplase offers a single bolus convenience with emerging evidence, while streptokinase is least favored because of the antigenicity. Because streptokinase, so high chance of antibodies formation and antigenicity, and also systemic fibrinolysis with a systemic bleeding risk is there with the so streptokinase. Even though you do catheter directed streptokinase thrombolysis, still there is a systemic like fibrinolysis and bleeding problem is there. So next, what is the current take home on thrombolysis in intermediate risk PE? See, suppose assume patient is not having unstable hemodynamics. Okay. But so his BP is systolic is not less than 90. So there is no drop in like blood pressure by 40 millimeters of mercury from the baseline. So then is there any indication for thrombolysis or not? What is the evidence? But so that depends upon whether he is having a dysfunction, RARV dilated and dysfunction, and biomarkers. Like is there any troponin positive or like N-terminal proBNP is positive. So intermediate risk is RARV dysfunction with normal hemodynamics with or without, so increase in troponin or like N-terminal proBNP or BNP. So that we call it as a intermittent or intermediate risk PE. So that is a submassive PE. What is the indications of thrombolysis? Should we do thrombolysis for all the patient? So this is the like data. Remember, normotensive PE with RV dysfunction plus or minus biomarker positive, that is troponin and BNP positive, that we call it as an intermediate risk PE. Okay. Piato trial, MOPED trial, so top coat Ultima trial. So these are some of the clinical trial, major landmark trial. So on thrombolizing a submassive PE, that is like intermediate risk PE. So like none of the data shows any sort of mortality benefit, okay, but decrease in hemodynamic collapse. But the problem is with increase in the major bleeding, including that of the intracerebral bleeding. So these are the findings of many of the like major landmark trials on using thrombolysis in intermediate risk pulmonary embolism. Okay, later we got some of the meta-analysis, again all suggest the increase in bleeding risk. So without any outcome, there is a mortality reduction. So only one JAMA published data, 16 RCTs, showed some reduction in mortality, but net benefit is questionable. Okay, even though it helps in decreasing the decompensation of the hemodynamics, but increase in major bleeding and intracerebral hemorrhage. Okay, so the final take-home message: in intermediate risk pulmonary embolism, systemic thrombolysis reduces hemodynamic decompensation but does not confer a mortality benefit and significantly increases the major bleeding in around 6 to 7% and intracranial hemorrhage in about 2 to 3%. Therefore, routine thrombolysis is not recommended and should be reserved as rescue therapy in clinically deteriorating patients. Very, very important take home in intermediate risk patient for the thrombolysis. Okay, so this is again, suppose you thrombolized a patient who is unstable hemodynamically or on a subjective and individual based, an intermediate risk patient underwent thrombolysis. Okay, so what is the anticoagulation plan? So when to start? Usually 3 to 6 hours after thrombolysis. Once APTT is less than like 2 times the upper normal limit, okay, then we can start the anticoagulation. Okay, avoid overlap bleeding. Okay, avoid overlap because of the bleeding risk. So initial agent, so unfractionated heparin infusion, so which is having a shorter half-life, and we can reverse with protamine if there is a bleeding. So heparin bolus, no need to give after thrombolysis. Okay, straight away you can go for 12 to 18 units per kg per hour than giving 60 to 80 units per kg as a bolus. Okay, so because if you give bolus, high bleeding risk, so post lysis, so titrated anticoagulation with infusion is sufficient. So monitoring target, so APTT of 1.5 to 2.5 time, so of the control value, or if you are monitoring anti-factor 10 level, so make sure it should be between 0.3 to 0.7. So that is a safe therapeutic range. When to switch? After 24 to 48 hours, if stable, no bleeding, okay, so then we can switch over to other conventional agents. Okay, so we need to bridge to low molecular weight heparin or vitamin K antagonist like warfarin, or direct oral anticoagulants, maybe direct thrombin inhibitors like dabigatran or apixaban, rivaroxaban, which are the factor 10 inhibitor on a long-term therapy. Warfarin bridging, overlap for more than or equal to 5 days. So maintain the INR between 2 to 3. So as long as INR is not in between 2 to 3, so you continue like anticoagulation with heparin and add the warfarin, adjust the dosage of warfarin. Okay, so direct oral anticoagulant only after stabilization, not immediately in the post lysis. Okay, so total duration more than or equal to 3 months. So in provoked PE, so like unprovoked PE up to 3 months is okay. So extended like anticoagulation is needed in unprovoked PE. So ongoing malignancy, recurrent PE, all these things are indication for prolonged anticoagulation therapy. Okay, so the take home: after thrombolysis for massive PE, start IV unfractionated heparin without any bolus once APTT is normalized. So then bridge to long-term anticoagulation once bleeding risk is acceptable. Okay, so coming back to our patient, so post catheter based mechanical thrombectomy, so early post procedure course, so hemodynamics improved, so his heart rate is 96 per minute, BP is 122 by 76 MAP is 90. NORAD requirement from 0.25, it becomes 0.03 mics per kg per minute. So lactate reduced to 2.4. Urine output improved to 1 ml per kg per hour, but respiratory status remain worsening. Okay, so respiratory rate is 32 to 36 per minute, saturating around 92 to 94%. So on like HFNC or NIV with a 60% FiO2, PO2 is around 70, PCO2 is 38 to 40, so it is rising trend. So work of breathing is increased. So because of the axillary, there is a axillary muscle usage is there. Patient is sweating. Okay, so is not able to speak continuously. Short phrases only is able to speak. So hemodynamics improved. Respiratory wise is deteriorating. We done an ABG. ABG shows pH of 7.32. PCO2 is 39. PO2 is 70. Bicarb is 20. So hemodynamic shock resolved. Patient having a worsening respiratory distress, so impending respiratory failure is there. Okay, so the question here is, what are the indications for intubation here? So either it may be airway related or increase in work of breathing, refractory hypoxemia, so impending respiratory fatigue, rise in PCO2, worsening acidosis. So again, if we add one more unstable hemodynamics, okay, so these are some of the indications for endotracheal intubation. Or we need to urgently transport, so urgent any surgical procedure is needed. So or you are anticipating a clinical deterioration. Okay, so how will you ventilate a patient with acute P and RV failure? So this patient undergone like intubation and mechanical ventilation. So patient in massive PE, you will have a acute carpal so acute RV failure is there. How you are going to ventilate? Okay, so primary goal is to reduce RV afterload and avoid RV over distension, because it helps in preventing RV failure and ongoing shock. So ventilation mode, either volume control or pressure controlled ventilation. So because it helps in predictable pressure and volume you can give. Tidal volume maybe 6 ml per kg of the ideal body weight. So avoid excessive volume because it increases the intrathoracic pressure. So compromise the venous return. PEEP low to moderate, somewhere around 5 to 8. So increase in PEEP. So increase in like pulmonary vascular resistance, decrease in venous return, worsening shock. So plateau pressure maintain somewhere less than 25 to 27, so that it helps in preventing the RV compression. Driving pressure should be less than 15. So it helps in limiting RV strain. Respiratory rate moderate, avoid tachypnea, so that if you have too much of increase in respiratory rate, so there is a inadequate expiratory time which add to auto peeping. Okay, so oxygenation somewhere 92 to 96. So hypoxia, okay, increase the pulmonary vascular resistance, that's why at least maintain saturation more than 92. So normocapnia, again hypercapnia will increase the risk of like pulmonary vascular resistance. pH more than 7.3, acidosis worsen the RV function. So permissive hypercapnia you need to avoid. So we don't want PCO to definitely like 60, 50 and all. So we want a normocapnia, because again, so hypercapnia will kick off the RV afterload. So adjuncts like inhaled nitric oxide, epoprostenol, so selective pulmonary vasodilatation. If there is a persistent increase in pulmonary artery pressure, we can use in RV dysfunction patient. So sedate, use relaxant, so like for short term, so that it helps in reducing the oxygen consumption and work of breathing. So conservative fluid, so that RV preload overloading can be avoided. So early norepinephrine, which helps in maintaining the coronary perfusion. So these are some of the right ventricular protective ventilation. Along with that, avoid arrhythmia, avoid dyselectrolemia. So maintain the sinus rhythm. All these things are very, very important. Okay. Question next is, when and how will you start anticoagulation post thrombectomy? So our patient underwent catheter based mechanical thrombectomy. So how we are going to plan for the anticoagulation? Okay. So anticoagulation in the post mechanical thrombectomy. So hemostasis is secured. There is no active bleeding. So within 4 to 6 hours of the post procedure, you can start anticoagulation. So recent major surgery or high bleeding risk, delay for 12 to 24 hours and again reassess. So ongoing bleeding or unstable surgical site bleed is there. So defer the anticoagulation and assess daily. Hemodynamic instability is resolved. So start once the map is stable, no escalating vasopressor requirement is there. Okay. So initial agent, again go for unfractionated heparin, so which is having a rapid onset, and we can reverse also. Dose, again don't give bolus, go for 12 to 15 units per kg per hour. So reduce which helps in reducing the bleeding risk if you don't give the bolus dose. Keep the APTT somewhere around 1.5 to 2 times, so which helps in tight control, prevent the bleeding. So if stable and bleeding is having a low risk, after 24 to 48 hours, switch to low molecular weight heparin. Okay. So long term, after like surgical recovery, you can go for direct oral anticoagulation or vitamin K antagonist for the secondary prevention. So after catheter-based thrombectomy for pulmonary embolism, anticoagulation is initiated early, preferably within 4 to 6 hours once hemostasis is secured. So using a IV unfractionated heparin without any bolus with later transmission to LMWH or oral anticoagulant based on the bleeding risk. Okay. So is there any indication for IVC filter in this patient? Patient is having a like pelvic fracture repair and massive pulmonary embolism. Is there any indication for IVC filter, or in which condition we consider for retrievable temporary IVC filter? Okay. So when like there is a absolute contraindications for anticoagulation, therapeutic anticoagulation, or we started the anticoagulation but there is a failure, or we started the anticoagulation and the complication happened. Okay. So these are some of the indications for IVC filter, which is a retrievable temporary IVC filter. Sometimes when patient is having a recurrent PE also, we go for IVC filter. Okay. So IVC filters are indicated in patients with acute venous thromboembolism who have an absolute contraindication for therapeutic anticoagulation, have failed anticoagulation, or develop life-threatening complications like bleeding. So particularly in the intermediate postoperative, in the immediate postoperative period. So prefer retrievable temporary IVC filter. Remember, so IVC filter, so per se are prothrombotic because they are going to cause the sluggish blood flow. Again, they may increase the risk of thrombus. Only thing is they prevent the movement of thrombus from the lower limb and reaching into the pulmonary circulation. So start anticoagulation as soon as the risk of bleeding is gone. Okay, even on IVC filter, patient require anticoagulation. So remove the filter early once bleeding risk is resolved and we are able to restart the anticoagulation. So that is on the IVC filter. Okay. So next 5 to 7 days, our patient successfully got extubated. RV size like improving. There is no RV dilatation. So anticoagulation translated into direct oral anticoagulant. So we planned for somewhere around 3 to 6 months of anticoagulation. Okay. Next question. Can you compare different DOACs option available as a maintenance therapy? Okay. What we can have the option. So we have apixaban, rivaroxaban, dabigatran, edoxaban. So these are clinically available direct oral anticoagulants in the maintenance therapy in so pulmonary embolism as a therapeutic range. Okay, so you can just go through this table. So apixaban, so which is a factor 10A inhibitor. So initial heparin is not needed. 5 milligram BD is the dosage. Loading dose 10 milligram BD for 7 days. So renal clearance, like if it is 25% or less, apixaban is not a good idea to be used. So at least it is among the DOACs, it is bit safest. So lower GI bleeding risk. So preferred in elderly. It is having a reversal agent called endaxanate alpha. So drug interactions are few. Dosing and convenience, it is BD dosage. So common preferred agent is apixaban in postoperative period. Okay. So rivaroxaban, again it's a factor 10 inhibitor. So again, no need for initial heparin. We can directly start with factor 10 inhibitor. So that is rivaroxaban. So 20 milligram OD, loading dose 15 milligram BD for 21 days. So 35% of renal clearance we can use. So we have to be a bit cautious as compared to apixaban when patient is having a renal impairment, highest GI bleeding risk. So elderly, we have to be cautious. We have a reversal agent called andexanate alpha. So drug interaction are few, OD dosage. Next alternative option to apixaban is rivaroxaban. Dabigatran, which is a direct thrombin inhibitor. So initial heparin is needed. So you thrombolized. So then give heparin for at least five, five more than or equal to 5 days. So then you can start without any bolus of the dabigatran 150 milligram BD. So loading dose other than 150 milligram is not needed. So it is 80% renally cleared. So preferably avoid in CKD and renal dysfunction patient. So bleeding risk is moderate. avoid in CKD patient, which we have like reversal agent, that is idaruzimab. Okay, drug interaction are more, so dosage is BD, bit less convenient, so it is overall less preferred. Okay, so the take home, apixaban best balance of safety and efficacy in elderly post ICU and GI bleed risk, where we have a high risk and all. Rivaroxaban once daily dosage is convenience, so higher bleeding risk with the rivaroxaban. Okay, so dabigatran or edoxaban, so require an heparin bridging before we initiate these agents, so less favored post like pulmonary embolism in ICU patients. Okay, so that is about the options of direct oral anticoagulants. So what are the long-term complications to monitor? Okay, our patient improved next 7 days, we extubated, we started him on anticoagulation. So long-term, we need to watch for chronic thromboembolic pulmonary hypertension, that is CTEP. So recurrent venous thromboembolism, post-PE syndrome. So patient might be having some sort of functional exercise intolerance. So how do you risk stratify PE after stabilization? Means like, okay, initial stabilization is done. We can use like RV imaging, biomarker trend, so functional assessment at follow-up, and we can use something called PESI and so SPECI scoring system. So PESI we have grade 5, okay. So depend upon age, so it gives an 30-day mortality. So depending upon the score, okay. So like score variables include age, sex, cancer, heart failure, chronic lung disease, heart rate, systolic blood pressure, respiratory, temperature, altered mental condition, saturation. So based on that, we have like overall classification depending upon the score value and a particular mortality. So PESI score, so risk stratification, okay, in terms of predicting the mortality after stabilization. Then SPECI we have. So SPECI we have 1 point for each, like age more than 80 years, history of cancer, chronic cardiopulmonary disease, heart rate more than or equal to 110, SBP less than 100, SpO2 more less than 90. So if the score is 0, low risk, so 1% 30-day mortality. If the score is more than or equal to 1, high risk with 8 to 10% mortality. So that is SPECI interpretation. So PESI and SPECI are clinical risk scores used to predict 30-day mortality in pulmonary embolism. SPECI is a simplified bedside tool where a score of 0 identify low risk patient suitable for the early discharge. Okay, so again one more indices to predict the mortality, shock index. Okay, like it is heart rate divided by systolic blood pressure. So normal shock index is less than 0.6 to 0.7. So shock index of more than 1, so most specific predictor of hyperlactatemia and increase in 28-day mortality. Okay, so we can have no shock, mild, moderate and severe shock based on the shock index, and when the shock index is more than or equal to 1.4, so then the mortality is almost 40%. Okay, so then we have something called modified shock index, where we have heart rate divided by MAP instead of systolic blood pressure. So shock index multiplied by patient age, that we call it as age related shock index. Okay, so shock index pediatric adjusted, we have some age related cutoff value for the shock index. So remember, there is something called shock index, very very important. Again, this is the table which shows the risk stratification scores in pulmonary embolism, so when to use. Okay, so their sensitivity, specificity, so like including PESI, SPECI, once we stabilize the patient. So SPECI is highly sensitive bedside tool to identify low risk pulmonary embolism, while RV imaging and troponin are more specifics for adverse outcome. So like European Society of Cardiology risk stratification integrate these to guide monitoring and reperfusion decision. So at least you should remember PESI, SPECI. So ECS risk model, okay, so which include PESI, SPECI score with RV imaging and troponin, okay, which helps in predicting mortality and deterioration. So high sensitivity, moderate specificity. So it integrate clinical plus that of the objective criteria. Okay. So this table you can just go through for the risk stratification in pulmonary embolism. Very, very important. Okay. So that's about managing so post-operative PE, risk stratification of long-term outcome, so predicting PE, okay, therapeutic options. So again, some image findings, okay, very, very important. We'll come back with many more case-based discussion. Till that time, revise, recall, and practice at the bedside. Thank you.